Hello, good morning. Thank you for having us, and we're very privileged. We're here live from MGM Healthcare at Chennai. I have a full team here, seasoned teams, doing all the cases. To my right is my wingman, Dr. Abu. We have Dr. Vivekan, Dr. Swapna, Dr. Smyrna from the anesthetic side, without whose help we can't afford to do any of these cases. So we have the entire technical team, nursing team. So we'll get on with the case history. So this is a 77-year-old man. He's a diabetic, hypertensive. He ended up with chest pain to a different hospital, and his ECG was abnormal and his troponin was positive. Was diagnosed with NSTEMI. He had an angiogram there. The angiogram showed significant double vessel disease, including the left main, the entire LAD and right coronary artery. He was very rightly suggested a bypass operation, but the patient was unkeen to have a bypass operation, and he came for a second opinion, and we have offered angioplasty based on his preference and his age, and we hope to do this today. His LV function shows normal LV systolic function, a LVEF of 60%, but clear anterior anteroapical wall motion abnormality in the form of hypokinesia. So it's still contracting, there is no scar. So we think whatever the LAD shows, it's worth revascularizing, and because he has symptoms. So let's show you the index angiogram done in the parent hospital. So you can see here, this is the angiogram done in January this year. You can see here the left main starts to get disease from the distal end, and there is a big chunk of calcium. I don't know if you can see the black bit before the contrast comes in, which is just on the superior aspect of the distal left main, creating that significant narrowing of the distal left main. Subsequently, there is a long segment of severe critical disease in the LAD, leading to low flow. It's sort of TIMI 1.5. I don't see that even reaching the distal end. So that's what we have. So you can see here the caudal views show a haziness in the distal left main, probably from the calcium, we think. Of course it could be thrombus too, but we will rule in or rule out with an IVUS today. The circumflex is a dominant system, has a large circumflex which largely appears unobstructed. Again, another apicaudal view showing the large circumflex system, a large OM. All of the circumflex system appears unobstructed, but the LAD is diseased essentially from the ostium, because it extends from the left main. So there is no way we can treat this LAD without involving the left main. I think that shows again the cranial views showing the entire LAD. We don't know where to end. I suspect once we open the LAD, we'll have a better idea, but invariably we'll have to go well past that diagonal is my expectation, but we will know in due course. Next. The right coronary artery, this is a codominant vessel, fairly large, very nice distal vessel, and has significant mid-vessel disease. So we're going to treat the right and left main and LAD. So I thought today we will start with the right coronary artery, just to make sure we have good right coronary perfusion, so that he will be able to tolerate the procedure, because we will have multiple times of no flow in the left system. So I'm just preparing the right to improve his coronary reserve from the right side, so that he will compensate for the left coronary intervention. So we're going to start with the right. So we've started with a radial approach here. We attempted a radial, but the radial was too small. We couldn't get a 6 French sheath, because I wanted to make sure we have 7 French axis, so that in case we need rotablation, we're able to go up to a 2 millimeter burr. So I wanted a 7 French. That was not going to be possible from his radial, which couldn't even take a 6 French. So we quickly switched to femoral. So we have a 7 French sheath in the femoral. I have taken a 6 French JR 3.5 guide. My intention is to treat the right first, and then we move to the left system. And as soon as we intubated the right, let's show the images today. You can see here it shows pretty much what we saw in the diagnostic images, but the catheter was too big and there was pressure damping, so we have a guideliner, we have a guidezilla. Today it's a 6 French guidezilla, which we hope to use as a guide extension to prevent damping in case we get that. So I put a wire down, so you probably can see the images, and I have pulled the catheter back and I'm happy with the pressure. So for now I'm not going to use the guidezilla, but we have that handy. Should we have pressure damping, we will use the guidezilla, which has an OD of 1.75, so it should happily sit there, allowing perfusion by its side. Okay, balloon 2.5 by 12 balloon, please. While we're going, perhaps my colleague, senior colleague here, Dr. Vivegan is also here. Perhaps we can ask Dr. Vivegan, what does he think? Any inputs from your end, Dr. Vivegan? Well,
morning, everyone. Like sir suggested, this is good a learning point that first to fix the right and then intervene with left, because right is diseased. So this is a learning point for me also. So we are going to fix first right and then deal with the left main to LAD, so that the coronary is reserve is safe and heart gets some pumping.
Okay, down. Go up. So you can see here there is a tough stenosis here, 14, 18, 20, 22, 24. It was not opening well, now it's opened with high pressures. We went up to 24 with an NC balloon down. Do a sizing shot. Go up. 18, 20. Okay, down. So we'll need a 12, 24, maybe a 32. I want to just go after the conus up till just after the distal marker of that balloon. So we're going to use a synergy stent. Do we have a 32? Yeah, okay, we'll take a longer one actually. We don't want to leave anything behind. We'll take a 38 then. 2.5 by 38, and then we'll need a 275 NC balloon, please. So that you just saw that, save that. The synergy stent just went in smoothly, just slid through. I want more proximal cover, so I've just changed my landing zone. Okay, I'm happy with that. Okay, let's go up there, Abu. Let's go up. 2-4. 2-4. 6. Slowly. So you can see it's a long stent. As always, we go very slowly so that you allow dumbbelling at the end. Allow the contrast to fill in and then go up to your nominal level, so that you don't want over expansion distally and then having a dumbbell shape. Okay, 12 and down, please. So we're going to post dilate this with a 275 by 12 or 15 NC, and then we'll do an IVUS to make sure our luminal endpoints are good. Okay, go up, Ma. Okay, down. So we're not going to go mad distally, but we will go high pressure somewhere proximally. Okay, go up there. 12, 14. 16, 18. Okay, down. Okay, go up. 14, 16, 18. Okay, down. So we post dilate with a 2.75 by 12 to high pressures. So let's have a look at the IVUS, and then we can decide if we are done with the right. So this is the IVUS setup we use here, which I'm a big fan of. So this is a HD IVUS. You can see here, this is the Boston HD IVUS. It's 60 megahertz. You get crystal clear images. I hope you can see the IVUS there. We're in the distal landing zone. Just do a pullback, please. So you can see the size is almost a 2.75 by 3. We have used a 2.5. Perhaps we may have to go higher on the outflow because I didn't go mad on the 275 balloon. Maybe I will have to. Let's see. Let's see the outflow. So there you can see the outflow of the stent coming in, and as expected we will have to go up with a 3 balloon. That's the best case scenario. So let's prepare a 3 balloon, please. Okay, let's see why the patient is going brady. Get a balloon quickly.
Atropine ready, sister. Get atropine ready.
Atropine ready. It's okay.
Get
we just
atropine.
need a. That's fine. It's fine. Atropine given. Can we give some epi? Also, let's give some perfusion. So probably the post dilatation led to some hemodynamic consequence in the form of bradycardia and hypotension. We're just correcting that. And then we'll redo the IVUS after. I did a quick check to make sure we don't have an acute stent occlusion or thrombotic formation. I'm happy with the flow, so we'll repeat the IVUS shortly. But perhaps rather than repeating the IVUS, we've seen what we need to see. Why don't we go with 3 balloon? Get 3 balloon. Let's not waste time. So this is a 3 by 12 NC quantum. And the reason we're taking the 3, you've seen in the IVUS, which we only did partially because of hemodynamic reasons we had to stop, very clearly shows the vessel is a 3 millimeter vessel, and we only put a 2.5 and then dilate with 2.75, and there's a lot of room. It just goes to show how much difference imaging can do, especially high definition imaging. It's very important. So we're going to go right from the outflow. We're going to go with a NC, cone down, stent boost. Okay, go up. Abu. 12. I think we've gone outside stent. Okay, down. Go up. 12. Okay, 14. 16, 18. 18. So we're going to go high pressures because we know the size is 3. There's no reason to shy away. We'll just go high pressures. 18, 20. Down. Go up. 20, 22, 24. Okay, down. So the patient has quite a lot of pain whenever we go up with the balloon. He's not tolerating it. I hope he'll get good relief once we finish. Okay, let's start. So we're repeating the IVUS again. You can see a 3 millimeter vessel. We are well past the outflow. We're pulling back here. There you go. That looks much better. That's a tight fit. I don't see any stent hang, i.e. no under expansion or malapposition. That's not there. It's well opposed to the atheroma, which is good, and we have a nice circular shape, and we have about 3 millimeters as we see. There was an area where we thought angiographically it was not well expanded, but we are just going past that, and I'm not worried at all. You can see here the MSA is well over 5, so you can be sure everything is okay. There's a bit of calcium there. You can see here there at 3 o'clock to 4 o'clock. Perhaps that's where there was a tight narrowing. We just managed to get away with high pressure ballooning. Here the stents are all well opposed again on the atheroma. In fact, you can see a little bit of prolapse between 2 stent studs. That's just a very good sign, which means we have done a good job in terms of apposition. So we're coming into the inflow. As we come into the inflow, I get the feeling we may have to go even higher, but there's no room. You can't oppose it to anywhere else other than the diseased segment. But here I'm very happy actually. The apposition is absolutely fine and very clean. I think the inflow, there is no there. You can see, you just saw the conus that came in at 11 o'clock position. I just want to have a quick look at the ostia. If there's disease all the way, you can see here there is osteal disease, but otherwise there's nothing critical. Good, excellent. So just shows the IVUS again, shows the inflow. I just want to make sure the inflow is good. Okay, we're just carefully looking at the inflow, making sure there's no under expansion or malapposition, and I'm very happy everything is well opposed and there's no inflow pathologies, no outflow pathologies. So all is good. There's a little bit of disease in the proximal vessel, which we knew from the IVUS, but do you want to do an MSA of the distal stent? Where we think there is a narrowing there on IVUS, the MSA is beautiful. Here you have an MSA of about 5 here. So on 2 views where we think there is a narrowing, it looks beautiful. Distal flow is very good. You can imagine why he had so much hemodynamic issues. It's a very huge PDA going all the way up to the apex on this RAO. So I'm pleased. We're done with the right. Let's move to the left system. Yeah. So we're taking a 7 French EBU 3.5, having seen the diagnostic images in preparation for a larger burr if needed, or perhaps even stool stent technique. But I thought we'll keep a 7 French handy, and we may or may not use the entire caliber of a 7 French, but it's useful to have one. And plus we are femoral, we've anyway put a 7 French sheath, so there's no reason to take anything smaller. And the left main ostia looked big enough to handle a 7 French. Small test. I'm struggling with this 3.5, just about at the ostium, but okay. Small test. No, it's come back. Okay, well, let's hope it's just a balance. You don't want too much guide, you don't want to damage the existing left main. Okay, looks okay. Pressures, please. Let's see if a coaxial looks coaxial. Okay, right. So the guide is coaxial. The 7 French is not too big for this left main. I think we can handle that. There's no pressure damping. And that's the first thing I'm looking at, and I'm happy with that. We'll proceed with the 7 French. Otherwise, I was going to downsize. There still continues to be that haziness in the distal left main. The circumflex looks faultless. So let's do some more views. Apicaudal. But the entire LAD looks pretty much the same as the diagnostic angiogram. We've not seen much changes. Okay, cranial. So in the cranial, we can see that chunk of calcium there. Give us a nice RAO, please. RAO cranial or RAO straight. I just want the entire LAD where the circumflex goes up north. Filter on northeast. Ready? That's a nice view. We get to profile the entire left main into the LAD, and you can see the entire LAD, the severe disease. LAO cranial, please. I'm just going to do an LAO cranial so that I can see the ostium of the left main, so that we have that in view. You can see that big chunk of calcium, so we will find out where that is. But it looks clearly it's in the distal left main into the LAD. But let's have a look. Y, please. I'm just going to give some nitrate, Dr. Swapna. Talker, please. Small test. So you saw the entry there, say that there was a big chunk which would prevent my straight passage from left main into the LAD, so you had to go down the circumflex route and turn back. So let's see what that is. Cranial, please. So you can see here, that's what is leading to that bend, because my push is being transmitted to the soft part of the guide. So we'll just have to deal with it with some caution. If needed, I'm prepared to take a microcatheter, a small test. Am I down a septal? Give me the reference, please. Okay, small testable. So we're down a diagonal, so I'm going to go try and see if we can get into this main vessel. There you go. I think that is the main vessel, I think. That's another diagonal. Okay, that's the main vessel. Yeah, I'm happy. Okay. There's a good chance we may occlude flow as we try and do IVUS, but we'll be careful. We made occlude flow now in the LAD, but we'll just be watchful. So we always have IVUS running even when we introduce, because you don't know what you're heading against, and it may be as you go in, there's some issue, no flow, low blood pressure, I may have to take it out, but at least if you have your IVUS running, you can have a peak of whatever you manage to get a peak off. But if it was not running, then you wouldn't get anything. So this is from the guide. So we always have it running as we even go in. No harm done. So this is the proximal left main. It's okay to go up from there. You can see I'm into the there. You can see a wide open circumflex. You can see that, and the ostial circumflex is absolutely faultless. You can see a big chunk of calcium here towards the opposite side of the circumflex ostium. This is a very nice demonstration where you can actually see the opposite side also, where there's a big arc of calcium. So I'm keen to debulk this. Without which we won't get good stent expansion, because if you don't debulk, what's going to happen is if you try and stent in this area, it's going to expand towards the point of least resistance, which is the circumflex area. So let's not allow that. That's a big chunk of calcium. You can see from 9 o'clock all the way to 5 o'clock, there's a big chunk of calcium opposite to the direction of the circumflex ostium. And I'm just going in. There's a little bit of calcium here. It's a big circumferential calcium almost, you can see here, and beyond which I'm struggling to pass my IVUS. You can see here on the catheter as it backs up, but I'm just pushing it with some force. This is all soft plaque. I think will cause harm beyond this. So I've seen what I need to see, so I'm going to come back. Did we record that, guys? I didn't do a pull back because I didn't get down distally where I wanted to go, and I think this also demonstrates my point where you start the IVUS in critical cases like this and go antegrade. There's no harm. By that we've got the information we need to get. So I'm just going to do a check shot, make sure we haven't caused any harm. Okay, there's nothing to panic. We just give some nitrate, please. So you can see here from the left main, there's a lot of calcium. It's a big arc. Okay, so this is the point that we really want to do something about. You can see here the circumflex is there from 12 o'clock to sort of 233. The opposite side is where the calcium is. So how are we going to debulk this? I think we're going to go with rota. And how can we make sure it's going to debulk there? Because one could argue the rota is going to keep going down the other side, the point of least resistance. That's what the rota will do. So we're going to take a stiff wire. We're going to take a rota extra stiff wire, and this extra stiff wire is going to make sure the wire bias is towards the opposite side. So if you look at the spider view, I want rota debulking everything on the top on this spider view. So for that I want a stiff wire with a wire bias whereby my burr is going to churn as much as possible in that area. So that's what we're going to do. So we'll take a 1.75 rota link, and I'll take a rota wire extra stiff. So we'll take a microcatheter in exchange. Give a microcatheter, we'll take that rota wire. That's fine. So we'll spend some time in the proximal left main to make sure we have adequate debulking. So I'm just trying to see what kind of a burr we need. I'm going to take a 2 burr because I want as big a burr as possible. It'll easily handle a 2 burr. So we'll take a 2 burr. Small test. Outer. Small test. Okay. Get back to a AP. Small test. Oh. Small test. Okay. So you can see here it's very easy to damage the left main with the 7 French. It's important to handle with care, otherwise we'll end up in trouble. So we're just taking our time here. Wire up, wire back. Small test. Once again. So same issue here. Small test. Where is that screen? No. So you can see I was just in the wrong vessel. It's like a dual LED, so it's important we go in the right one. Again, there's another diagonal there. Let's So I'm just spending some time making sure we get the wire as distal as possible because we got to exchange for a rotor wire. Once the rotor wire goes in, usually it's very hard to manipulate through this calcium. It becomes a mess. So I'm just taking my time here. Rotor wire, please. So I'm just following my wire with a microcatheter. You can see here, I hope the microcatheter will fly through. Okay, it is flying through, which is good. So you can see there. Save. Rotor wire. The rotor wire is extremely difficult to see. You only see the distal end, which is radio opaque. So it's important, you're happy that your microcatheter is as distal as possible. The most important thing I've seen is you just want to be absolutely sure you don't bend the rotor shaft at any of its course, because if it bends, you'll get the burr stall. So just handle the rotor wire as soft as possible because you don't want any acute bends. So it's very important that is taken care of. So that's the rotor wire going in, and I'm happy it's all okay. Let's swap sides, Dr. Abu. I'll just take hold the guide, we'll exchange. So I'm going to take the microcatheter off, and you can either use an assistant, or you can also put a anchor balloon and do it too. But here Dr. Abu is very skilled and he's done a lot of rotors, so he's just helping me here. So you may want to show. So the whole system consists of a burr and an advancer. Up to 1.75 we have a Rotalink Plus, which is everything comes attached, you just have to put it in. But after 1.75 we have a 2 burr, we have a 2.25 also. They don't come as a Rotalink Plus. You'll have to take the advancer separate, the burr separate, attach it. I will show you how to attach it today. So this is the rotor advancer. It comes in a pack. This is the first thing you got to do, is to take it out. Then this is the fiber optic cable. That's what handles your pedals. It's important your table is all set for rotor people are used to where the cables go, and it's important your rotor wire, everything can move over a long distance. So this is our routine. We give it on the far end. And this is the gas tubing. This is where the gas, which is nitrogen, which is pumped in for advancing the burr. Here we go. Santosh. So once these two are sent away, you want to nicely pair these two so that there is absolutely free movement at any point. Artery forceps. Okay, now the fluid. So this is the third connection I want you to show here. This is where the rotor fluid, you can use the ready-made rotor fluid that comes with the company, which is the milky stuff, or you can make your own fluid. So we have made up a fluid here. So what that includes is switch off there. I'll show you in a second. So this is a fluid in a 500 ml bag. It has 2,500 of heparin and 2 of nitrate also. And we run it at a speed which I will show you in a second. So this is all connected, and you can run the speed through this adjuster, which we are all familiar with. So I want you to focus here. Can you see here? This is the advancer knob. As we move it, you can see the shaft coming out. Now this is where I'm going to attach the 2 burr onto. So I'll show you that. So this is the burr that comes separate. So you can take a 2 burr, or you can take a 2.25 also. We have both here. So I'll show you a burr here. This is a 2 burr. Looks pretty bulky. Can you see this nicely? Okay, so this is the 2 burr. So we will keep this protected. So this is the protecting sleeve. Let's not remove that. So I just took it out to show it to you. So make sure all knobs, everything is taken out. Now this is an element that I want you to see if you can concentrate, but I don't think the resolution of the camera will allow you to see. There is a little bit of an indentation into the shaft. I don't know if you can appreciate. So this is what goes into that, and then I will lock it with this little sleeve. It looks medley, as you can see, but you know, once you get the hang of it, it doesn't take too long. Just take your time with it. Okay, this is attached now, so I'm advancing this. That's it. Can you see here? So I've advanced the sleeve over it. Everything is tight. I'm happy. I put it back, and that's it. So everything is ready. Now we're just going to make sure the fluid comes out nicely. So you can see here the fluid comes out between the sleeve and the rotor shaft. So this is the lubricating fluid. If this fluid doesn't keep on flowing, your burr will stall and it could stop. It may not flow easily. In addition, this fluid has a little bit of heparin and nitrate, which I told you, which will keep the vessel open, prevent spasm, and prevent thrombus, which are the other complications of rotablation, because acute vessel closure is a complication. Of course, the most important complication is perforation. We'll keep an eye on that. And we keep covered stents here in the lab. It's always our policy. But here you may not have much room to put a covered stent. Where we're going to rotablate is right at the distal left main. So I'm not sure we'll be putting a covered stent here. We'll probably resort to other methods. So what is the rate you want to free flowing it at? So I'm just going to adjust it. So this is the rough rate you want to be flowing. You don't want too much, because otherwise your pressures will come down. I'm just adjusting it to make sure it's just about 1 ml per second. Yeah, that's good enough. Okay. Rotor pedal. Next, you want to make sure it's working. So, our rotor is set to stall. That's nice. Yeah. So all is running, everything is good. So we're set to go. You can see here what Dr. Abu has done. This is our routine. Can you see here? So the end of the wire is connected to the talker, and you can defeat the brake like this. So therefore, the brake is not on, which means the wire will move freely. If you take it off, the brake is on. So we don't want the brake on because we're going to introduce it. So we want the wire moving freely. So as I introduce, this wire will get bigger and bigger. So you can, even one person can do a rotor too, but it's just a point you want to bear in mind. Are you on dyna? So I'm just going through a dyna mode where it rotates at 50,000, 60,000 revolutions per second, just to ease matters. So I'm there, right there at the guide entrance. So I've not come out of the guide because my guide is inside, and if I come out, I will occlude at the point of narrowing. So now we're ready to go. So here I'm going to defeat, come off defeating my brake. Here you go. So there you go. So everything is set. So it's important. Now you don't want the wire moving. Yep. One could also put a temporary wire also, but we usually don't. We manage to get away. We just do short runs, slow runs. So we'll do at 180. So one of the good things about a 7 French is, even with a burr, you can get some contrast through, because otherwise it's very difficult. So I'm just making sure we're all okay. So I'm going to rotor only the proximal end up till that diagonal. I'm not going to go beyond because it's not big enough. You can see there's some resistance here. There you go. It just went through. Let's give some gap. It's bradycardia. So the rhythm is coming back. We just had to give some time because you saw there was a point where my burr went and almost stopped as I was burring, and that's the point of maximum calcium. But there is the point I don't want to push. I want gentle rotablation to try and churn as much as possible, because the wire bias is all towards the lateral side. So let's say you have circumflex, you have LAD, my wire bias is towards the LAD, and that's where I want maximum churning. So let's see, we're bound to get some bradycardia. We'll just have to bear with that and deal with it. We can put a temporary wire if you want, but usually we get away because I think the important thing is, as soon as you get the burr out and allow flow, usually heart rate comes back. I just want to come back in the guide. Okay. So I just want to put it back into the guide while my guide goes back into position, and then we'll restart again. Show us the spider, make sure we're in. So yeah, so we're okay. So we'll probably rotor on the spider view here, so we'll know the wire bias nicely. Ready? Okay, it's a little bit of bradycardia again. Let's just get it back. Dyna, I'll get it back into the guide. Okay, right. Now I'm going to go to the cranial view because I want to make sure I don't advance my burr beyond that dilated portion in the mid LAD, because beyond that taking a 2 burr is risky because I don't know the diameter, I've not seen it. But until then I've seen it, so I know I can happily take a burr. So here I'm just checking how long I should take my burr until, so I have a fluoroscopic landmark. I'm going to go up till the middle of the screen, you can see there. Right, 180 ready? Dyna again. Okay, I think we're done. Ready. We're going to come off. So we're going to defeat the brake again. You saw where I went up to the point of the concentric calcification that I showed you on IVUS, and that's where we had a lot of resistance that then gave way at a point. You probably appreciated that, and I made 1 or 2 polishing runs. Now we'll take the IVUS out, the rotor out, we will dilate, and then we'll take it from there. Perhaps we can see with an IVUS also what we did. So this is just a safety shot. We'll make sure everything is okay. So there's just no flow there, which is okay. You can see here already the diameter is quite big there. Wherever we rotablated, the slow flow should resolve. Now that we have completed the rotor, it should resolve in due course. Let's take it out as quickly as possible. Get a 2.5 by 12 balloon. Show the wire in view for me. Let me know once the wire comes out. So you need a lot of room, you can see here. Just prepare adequate room. Okay. Microcatheter, balloon quickly. Nitrate quickly. I think the important bit is when you get spasm, you want microcatheter to go in, because otherwise you can't give drug distally. It is not going to go and act in the distal LAD. It's important you don't keep giving drugs now when there's no flow, because whatever drug you give, it's not going to get to the point where we want it to act. It's important we quickly get a microcatheter and deliver the drug through the microcatheter. Otherwise you won't get what you need to go, where you need to get the drug to act. So a little bit of resistance here. Extra support is better. Whisper extra support. So I'm just giving some nitrate down the microcatheter, and hopefully that should open up the distal vessels. Usually it's spasm. I think I've opened up the distal vessel, but now the microcatheters are including another narrowing, so I'm going to get rid of the microcatheter and get a indeflator to blow it off. What I'm doing here is trying to blow off this catheter, so otherwise you'll have to put a docking wire. Okay, go up to 12, Abu. Ready? 14. Maintain. So Dr. Abu is maintaining my pressures at 12, 14. As I push the wire, I'm pulling the catheter out, so that without an exchange length wire or an occlusion balloon or an anchor balloon at the guide, I'm just getting away. Stop. Okay, the catheter is out. Now I'm hoping we should get flow. Let's see if I'm right. We should get flow now. Balloon now. That's good. So we're back on track. So I have not ballooned anything. I have not used a single balloon. I have just rotablated. Just see the difference of the proximal LAD with the 2 burr, where the lumen gain angiographically is plenty. So we will check this again on IVUS. But what I'm going to balloon now is that you see that little narrowing just after that diagonal. That was quite tight, and perhaps with the spasm everything blocked off. I put a microcatheter, opened up the distal vessel with nitrate. I'm just going to balloon that. Once we balloon that narrowing after the diagonal, I think we'll have excellent flow, and then we'll restudy, and then we will be in a position to stent. But I'm happy with the lumen gain without any ballooning, just with the 2 burr. Okay, go up there. 14. Save. Okay, down. Okay, next we'll do IVUS. I think that should have opened it. Let's see whether we're right or not. That's much better. So let's do an IVUS now. We'll do an OCT. Can we just go back on the last rota where there was resistance at that point and then that moved, gave through, just for the viewers who didn't get a chance to catch it. Here you can see this is the last run. I couldn't go past where the burr is stalling there, but we just persevered, and at one point it gives through. There. Did you see that? That's it. That's the narrowing which was circumferential on IVUS, and I'm glad we opened it with the 2. I guess one could argue why can't you use a smaller burr, but I just go based on IVUS. You know, we do an IVUS, we know the size. There's no point in undersizing when you're not even going to touch the lumen. You know, I want a burr size to the lumen that I see on IVUS, so that I have adequate debulking. So sometimes we go with a 2.2 burr. We have that. This is generally a lack of stock of these burrs, but we just stock it and hide it. Okay, so the IVUS catheter is flying nicely, which it didn't do before. So let's do an IVUS now. Let me just show you the angiographic marker where the IVUS is parked. So it's way beyond. We don't need to go up till there, is it? Let's come back. Okay, so we'll start somewhere from there. So it's about 2 millimeter there. You can see there. No need to flush. This is beyond the diagonal. I think no need to flush. So we should get the diagonal shortly. This point is pretty good. Can we bookmark here? Maybe we can treat up till here. So you don't want to go any distal to that. So that's the diagonal. You just saw that in the 2 o'clock position, and that's the point we probably burred. You see that lumen gain? I'm very pleased that we took a 2 burr, and this is without any ballooning. This is probably the already wide part. So this is the narrow part where we did quite a bit of rotablation. I think it's debulked very nicely. Just with the burr, we have good lumen gain. I think most of the calcium is gone that we saw from 3 to 6 o'clock. And here there's a little branch. That's the circumflex coming in, and I'm quite pleased to see even the distal left main proximal LAD calcium has been debulked also. We'll see that again shortly. I just want to run the entire IVUS just to get up to the aorta, make sure the ostium, everything is okay. Okay, that's the aorta coming in. We've not done any damage. Okay, good. Thanks. The burr can come off, no more burring. So I don't know if you remember, we had quite a lot of material just opposite the circumflex ostium, which I'm showing you now. That is all significantly debulked. It looks quite polished there. I'm pretty confident we can dilate it to a minimum 3.5 vessel to put a stent there. Okay, let's take a bookmark. Show us the bookmark where we started, please. This is the distal bookmark. I want to start stenting from here, i.e. I want to start stenting from after the diagonal where the vessel is about 2.5. That's what I'm going to take. Let's go proximal. Bit more. It's a small diagonal. Keep coming. That's the circumflex. So stop. Bookmark here. Okay, so that's B6. What is the distance from B1 to B6? So from the ostial LAD to the stent outflow, it's 30 millimeters. Okay, let's come into the bring the IVUS into the left main. We're going to stent it to the left main. So this is just at the aorto-ostial junction of the left main. I don't want to go into the outside the left main because it's not diseased. It just invites flaring and all the other complication that comes with it. So can you measure from B7 to B1? So B7 to B1 is 40 millimeters. So the length of disease that we're going to treat today is 40 millimeter, and the length of the disease from exactly the left main the LAD ostium to the distal end of the stent is going to be 30 millimeter, which leaves us with 10 millimeter in the left main, which is good enough for a port balloon. It's very important we know what is the port distance we're going to have so that we plan our stents according. So we'll take a 2 stent strategy here rather than be aggressive with one. What is the longest synergy that you have? 38. So 48 we don't need, it's a bit too long. So we'll take 2 stents. So why don't we take, we'll split it, we'll take 24, 24, take a 24 2.5 and then we'll take a 3. Yep. So the left main, you can see here the IVUS is at the left main, it's 1, 2, 3, 4 millimeter. 3 stent will happily go to 4 millimeter. The Boston manager here, Sridhar, says it'll go up to 4.4. 2.5, but we don't need that, we're just going to take 4. So there's plenty of room. So just 2000 heparin given. Flush. Get a 3 balloon next. So I'm just taking a 3 balloon, although I've seen enough on IVUS just to be absolutely sure that I can visibly see a structure that's going to 3. Okay, go up. 12, 14, down. 14, 16, 18, 20, 22, 24. Okay, down. Okay, go up. 24. 24. Okay, down. Contrast should be reduced. It's very slow. Stent next. 2.5 by 22, 24 synergy. So the stent is flying in nicely. So I've not faced any obstruction at all. This is a synergy 2.5 by 24. Prepare. Okay, go up. 2.4. Slow. So we're not going more than nominal because the distal is just about 2.5. I don't want to go too mad because there's quite a lot of disease we saw even distally. We're not interested in treating that. We just allow this flow mediated dilatation at a later point to enlarge that vessel that's probably not been perfused for a long time. Looks well expanded to me. Okay, down. Okay, go up there. 12, 14, 16. Okay, down. So let's just size this now. This is a fairly long stent, so come Elio. So we'll probably park on the lower curvature of the left main. Small test. Okay, this is good. We'll come back a bit. Small test. Okay, go cranial. Let's see. We just left the marker at the middle of the ostium, we think, and we'll see how much extra stent we have. No need contrast. Stent boost. So we only need half this marker to marker length, as you can see. So this is 24. So we will only need half, which is 12. To allow overlap, we'll take a 16. Looks good. Yeah, 3 by 16. Of course, during this stent implantation, we will have no flow in the left coronary at all. So we'll be prepared for that. We need to have a pod balloon ready, available quickly. We need to have an extra wire ready to cross into the circumflex if there is a problem. And we need to have a 2.5 balloon dilatation if there is acute shutdown of the circumflex. So we're going to take a 3 by 16 synergy from the inflow of this middle AD stent up till the left main. I expect to have at least 6 or 8 millimeters into the left main, and then we will pot it with a 4 balloon. Cone down, supermag, we don't need anything else. We don't need the distal vessel. Minimize overlap, so I'm happy there. Okay, prepare. It's quite a lot actually. Go in a bit, we don't need so much. We don't want any stent outside. So just come a bit more. There's a little bit of overlap. I don't want overlap, sinus overlap. So spider roughly tells me how much pot distance I have. I have fair distance actually, so it's okay. Back to cranial. We have a good overlap though. Okay, go up Abu. 2, 4.
3, 4, 5, 6, 7, 8, 9, 10,
12, 12, 13. Okay, looks good. 14, 15, 16. Down. Okay, the pressures is going down as expected. Hopefully we should get perfusion, bradycardia. It should correct itself. So let's just give it some time, get the guide out, and hopefully it will correct. So there you go. You can see the pressure slowly coming back up. So that was expected. We don't need to go up on the drugs. We'll just have to wait, and it should recover. Okay, let's go up there. Let's do the overlap. 11, 12, 13, 14, 15, 16. Okay, down. So this is a point where I would urge to be very slow because the ostial left main stent is literally hanging. We have not potted it. So make sure the guide doesn't get sucked in and damage that bit. So it's important to keep the guide well out into the aorta, or you can leave a safety wire too hanging in the aorta, which will be a good way to make sure this guide doesn't get in at all. But as long as you keep it under view, you do it meticulously, it's okay. But we do at times leave a safety wire too. 4 pot balloon please. So let's say where we are, just a safety shot. Everything is flowing as expected. So I went up to 15 or 16 or so in the stent, so I expect to have achieved about 3.2. So there's a little bit of a carinal shift there, which I hope to correct with a pot. But otherwise, I'm happy. All right. So we're taking a 4 into 8 NC. Okay, ready? Abu, go. 8, 10, 12, 14. Okay, down. Okay, let's do another stent boost. Okay, looks quite well dilated. Just come back a bit. Okay, go up again, Abu. 12, 14, 16, down. Down, down. Go up again. For some reason I just want to do it. Okay, go up again.
12, 14.
14, 16, 18, down. One of the things to bear in mind is you get a lot of blood loss in a 7 French or an 8 French guide because as you keep the O-ring open, just have to factor that in. And of course you get a lot of dye too, so you don't want to push your full injector in when you do it, so it's best to. Okay, it looks nice there. It's well opened. Once we did the pot, the carinal shift, everything has been corrected. So let's see where we are. Let's do an IVIS. Cranial. The distal vessel is still small, but now that we've corrected, I hope that this will slowly lead to flow mediated dilatation at a later stage. It's a lot of spasm, but otherwise angiographically I'm happy. We have good lumen gain of the entire deceased segment. Let's have a look. IVIS. Pull back. So we've gone into the disease segment. We're going to come back. Okay, pull back. There you go. That's the stent. Really tight fit. We couldn't have got anything bigger. That itself is probably oversized for that vessel, but that's okay. The lumen gain seems to be pretty good. The apposition is pretty good. So that's the circumferential tight segment that we had, and I'm very impressed with the lumen gain there. Very tight fit. We couldn't dilate anymore. You can see here there's hardly any room. Any more dilatation, it's going to rupture at the point of resistance, which was around the 9 o'clock position there. And there you see the wide open circumflex, and that part really is very good looking to me. I don't know what the audience feel, but it's very pleasing to me. And the stents in the left main are well opposed. We couldn't get anything bigger, and there's nothing hanging out in the aorta. I think that's a very pleasing result. I don't think we need to do anything more at all. Okay, everything out. Okay, I think we're done. This is the disease segment. This is the inflow of the stent. Absolutely no inflow pathologies. Keep dragging back. Come all the way slowly. This is just a review of the IVUS to show procedural endpoints, luminal endpoints. Keep coming back, all the way back, all the way back. Show us the circ. Great. Show us the circ. You can see there, look at that wide open area. If you remember how we started, where the lumen was, where the calcium was, everything has been debulked. The carinal shift has been corrected with a pot. Wide open lumen. We don't need to do anything at all. Come back into the left main. There you go. And this is the potted left main stent. Wide open at 4, probably more than 4 actually. But that's good. Let's check the angiographic endpoints. Nitrate. Looks beautiful. Caudal, please. Spider. I think it looks very nice. Okay, we're done. So we will close the puncture site with an 8 French angioseal. Check on the groin, please. We always put a mechanical closure. I think that's very important. Okay, 8 French angioseal. Okay, so you can see it nicely here. I put a wire through the 7 French sheath. Then take out the sheath, hemostasis with your fingers. The 8 French angioseal sheath with the dilator fixed goes in, and I'm here looking for blood coming out in this direction to know when I'm into the lumen. So here you go, blood has come out, I'm into the lumen. So the dilator comes out leaving the sheath, which means my sheath is still inside the vessel. Now I'm going to put the anchor, and as I put the anchor, this is what is going to happen. This anchor is going to open inside the vessel, which I shouldn't be doing. It's against the IFU, but I'm just demonstrating for the purpose of the audience. So I'm going to put the anchor down. Now locked. Now with counter pressure with my fingers, I'm pulling, which means the anchor is in the intimal aspect of the vessel. I'm pulling nicely with counter with my fingers. Now I'm going to change my counter to the collagen and push it close, which means here you need to get this black marker. I don't know if you can appreciate. If you get this black marker, it means you have approximated the vessel well between the intima and the adventitia with your anchor and collagen. So that's what you need to achieve. Because if you get that, usually hemostasis is perfect. If you don't, it means you got a lot of tissue intervening. And you can see here, we have not checked ACT. We never check ACT for closure, because you only need to check ACT if you're going to press with manual pressure. If you're going to use a mechanical system, absolutely not a single drop of blood. Everything is done and dusted. Okay, with that, we are finished here. The gentleman had a successful angioplasty angiographically. He had a left main to LAD rotablation, achieving excellent lumen gain with adequate debulking with rotablation, which I don't think we could have achieved with any other technology, resulting in a good stent expansion, beautiful angiographic result, and the pot has done justice to that circumflex ostium, achieving a very good intravascular imaging endpoint. The right, of course, was straightforward. You saw that. I think this will really help the gentleman, saves him a bypass, and we expect him to go home in a day or two. Thank you very much, and thanks for having us, and thanks all.